And so everyone should have received, for example, an invitation to this meeting, but also should have received an invitation to the to the Zoom-based monthly call last month and next month. So we're working through to kind of reconcile the lists, but if you did not get both of those invites, let me know and I'll make sure your name is on both lists. And apologies for the problems. With that, I'm going to turn it over to Dr. Ketchnick, who's going to make some executive comments here.
Hi everyone. Good afternoon, and I think it's good afternoon probably for most of the folks that are on. I'm not sure for those that are joining us for the first time today, welcome. And I am Dr. Decker's helper, but I'm also the executive officer for the non-disease site committees such as radiation, surgery, and imaging. So I'm going to share with you some opportunities for being a committee member, some opportunities for funding that I mentioned on the last committee meeting last month, and also sort of what's kind of hot and going on in all of SWOG right now. So next slide. So just from my vantage point, this is what I see as opportunities for you on the radiation committee. Just because we're not a disease site, there's many of us that have been PI on new concepts, either at a disease site or in NCORE, which is cancer control and prevention studies, survivorship, health disparities, and palliative care. So just because we're not a disease site committee, we can help support great ideas with either the disease sites or the NCORE side of the house. You can also be a co-investigator for a secondary endpoint on developing protocols, especially with a modality of radiation that often needs to deploy some peer review. There's a huge opportunity for secondary analysis. Dr. Horowitz, who's on, worked as part of the surgical committee with some of our surgeons to do a secondary analysis this year of SWOG 0809, which is our cholangio gallbladder postoperative radiation study. Just a single phase 2 arm trial, but there were a lot of questions that weren't answered in the primary endpoint paper that both a surgeon as well as Dr. Horowitz did, and it just had an endpoint of 2 important abstracts at both ASCO and ASTRO. So again, there's a treasure trove of lots of data to be mined, many with radiation DVHs, etc. And I know we have our folks from IROC on who can provide information for that if anyone is interested. Also, if we go back live in the fall, which we may, not totally decided, but it's looking promising. There's always travel grants for new and junior members. And on the next slide, I'm going to review all of the Hope Foundation grants. Next slide. So there's lots of different potential funding opportunities from our sister organization, the Hope Foundation. The first is actually coming up if you're interested in it to apply, and this one's pretty low-hanging fruit. And this is a virtual grant writing workshop for investigators that are thinking about future grant submissions. So again, pretty easy and free to all of us, but you have to apply. The next one is a great one. It's the Young Investigator Training Course. And this usually takes place in the fall, usually live. It's a week at our core statistical facilities in Seattle at the Hutch. And it's a multi-day, very intensive course where you learn all about SWOG and all about being a new investigator, as well as developing a trial. So this one to apply to takes a little bit more homework. So you may want to think about it for next time too, unless you have a trial that you've been working on, because to kind of get invited to this, it's always good to have lots of letters of support and recommendation for your initial concept from the individual disease site or NCORE committee chairs to say, okay, we're interested in this concept. Let's have you help our young or new investigator to develop it. The one I just reviewed grants for last week was the SWOG Hope Impact Award. This is a nice big one. It's $250K over 2 years for a 1 to 2 year project. And it's really a way to get interesting initial data, which hopefully will either lead to some sort of new discovery or inform a new trial. And again, anybody interested in any of these things, I've had a long history in SWOG reviewing the grants and applications, and I can help. I mentioned secondary data analysis. Out of all the 4 adult groups, the process to do these is easiest here at SWOG. Basically, you could come to us with an idea, and all we have to do is submit it to whoever is the chair of the committee where the trial took place. It's usually approved pretty quickly, and they provide us statistical support with the statistician who's on that committee. And then the next one are seed grants, $50K direct cost. And again, similar to the HOPE, but sort of a smaller scope to fund preliminary research. And this could be lab research that may potentially translate or inform a future trial. So for instance, potentially you're looking at some sort of biomarker that you might test on a future trial. And then for those of you that are within VAs, there's actually separate VA support, which again, there aren't that many people that apply to these things. So on a good year, there might be 10 applications, and just think about this versus something from the NCI where there's more ends and it's much harder. So if you go into the Hope Foundation website that I've listed and really take a peek, and we can help you with it. Next slide. All right, so what did I find out? What I found out in the last couple months as an executive officer at SWOG. This one I just found out like over the last 2 weeks, and I never knew this, and I've been on SWOG since 2000. We're the only group that actually collects Social Security numbers. I'm not sure any of us knew this, because usually you're lucky if you get zip codes on most trials. So think about, from a radiation long-term toxicity perspective, on any of the trials that we've done at SWOG, you can actually leverage Medicare and actually soon all payer data. So another thing to think about for actually big data secondary analysis. All right, next slide. And lastly, I'm not sure everyone knows, but the overall group chairs for our adult groups actually meet with the NCI director monthly, talking about sort of what the NCI is thinking about for big funding opportunities in the next year. And here's what Dr. Ned Sharpless is thinking about. He's thinking about cell-free nucleic acid. And I pondered myself, okay, I know all about circulating tumor DNA, which is sort of the buzzword to put on all developing trials right now. But what about cell-free nucleic acids? And basically, they're small fragments of DNA and RNA that replicate the genomic features of your tumor and are expressed into the bloodstream, even at the sort of development stage of a cancer. There's a pharma company, Grail Science, that's sort of leading the way and building big data sets. One of their trials that is open is the Pathfinder study. It's involving the Dana-Farber and a few other big centers, again, trying to gather data to kind of make AI algorithms for prediction of cancer, and hopefully at some point also for looking at treatment-related outcomes. So something to also think about for all of your developing studies. And I think that's it. Does anyone have any questions? We actually have a record of 88 attendees today.
I know it's a great group.
I will put my email into the chat, or if you guys want to also chat me questions, I'll follow that as well while we have our other presentations. And thank you very much.
Thanks, Lisa. So let me see. If there's no questions or comments, so I heard back from several of the disease liaisons that they have conflicts later. So I thought we would start by going through our disease liaison reports. You know, when we do this in person, we used to kind of go around the table. One of the problems here is everybody's around the table looks different these days. So these are in fairly random order, but I know Reshma has a conflict, so I'm going to put up her slides first, or at least I'm going to attempt to. We will see how this goes. There we go.
Thank you so much.
All right.
Okay. Well, excellent. I can whip through these quickly because I know this isn't supposed to take long. So we have one active trial. If you give me the next slide. And actually, it'll be the slide after the next slide. And that is our phase 2 randomized trial of olaparib being administered concurrently with radiation therapy versus standard radiation therapy alone for inflammatory breast cancer. Next slide, please. This is the schema of that trial. We are up to 76 patients accrued in this rare patient population. We're not quite at the accrual goal of 5 patients per month yet, and so we're discussing whether to allow BID radiation on the control arm as another form of standard radiation to appeal to more centers that may be using that as standard of care. So that's what's going on with that one. Next slide, please. We've got a couple of exciting trials in development. Eileen Connolly is going to present later in this meeting about her fascinating concept that she's presented here before regarding IORT for DCIS after breast conservation. Corey Spears, who can't be with us today, but who will hopefully be able to present on one of our working group calls very soon, has already presented a concept on CDK4/6 inhibition concurrent with radiation therapy for ER-positive locally advanced breast cancer. Similar study design to the 1706 trial, and building on his really important preclinical work in this space. Next slide, please. We have a couple of championed trials in other groups. These include Taylor RT and Deborah. Next slide, please. Taylor RT is the, I guess I'm going to tell you about Deborah first. Deborah is the omission of radiation in low-risk patients, and it's being championed by Dean Shumway. Next slide. I may have lost the Taylor RT slide. If I did, I'm sorry.
No, I went too fast.
Super. And then Taylor RT is our trial that is a randomized trial of regional nodal irradiation in patients who have biomarker low risk node positive breast cancer. And that's being run by the NCIC. Next slide, actually past Deborah onto the very last couple of slides that I have. We also have some other work ongoing, including soon to be done a secondary analysis of radiation treatment use and local regional outcomes by oncotype recurrence score and radiotherapy receipt in S1007. Study chair is Kevin Kolinsky, and as soon as they're done with the primary outcomes analysis, which they're almost done with, they've already presented at San Antonio, then a group of us, including Wendy Woodward and Eileen Connolly, will be working on the secondary analysis of the local regional endpoints. And then genomic signatures and local regional outcomes will also be something that will be looked at in S8814, potentially led by Corey Spears. That is it for us. Lots of good stuff.
Great, Reshma, thank you. All right, how do I stop sharing? There we go. And any comments or questions about the work they're doing in the breast? You got a lot of projects going on. It's fantastic. All right, seeing no questions. Great, thank you. All right, so seeing no questions, I'm going to move on. Now, Chelsea Pinnix sent me a slide presentation from the myeloma committee, but her, I think, working group committee is right now, so she's not able to attend. I am going to show her slide and not do it justice at all here. So just to give everybody a picture of what they're doing, there is a trial proposal in, oops, let's see, there we go. There is a trial proposal in front of the myeloma committee for, there we go, solitary bone plasmacytoma, which is radiation alone compared to radiation daratumumab, Revlimid, and dexamethasone, which actually looks, I think, very interesting. My understanding is they are having some accrual challenges, or at least some perception of accrual challenges. And so they're kind of working to address these. And I don't know if anyone else knows more about this, please feel free to jump in. But Chelsea was unfortunately not able to be here today.
So Roy, is that a trial actually open to us? Oh wait, you're on mute.
Sorry, I'm having the clickies today. Yeah, I just keep clicking things randomly. It doesn't seem to be helping. My understanding is that's a trial proposal that's kind of been discussed, but I don't believe it's open yet. I think there is a concern that there may not be enough patients for it. She said she would try to join later on if their meeting ended early, but I'm not sure she'd be able to.
Maybe we can recommend a survey. That seems to always be helpful when we're trying to pitch a trial, and we could, this is a little bit different. SWOG is unique in this. There's actually a committee that oversees surveys, and we have to submit our survey request to them, but I'm sure it'll be fine. But I would recommend that because the NCI likes to see that as well.
Yeah, I would agree. We've done that for a couple of our studies, and it has answered concerns at triage. It's answered concerns, at the NCI steering committee. It's very easy to just whip out and say, well, we did a survey of our members, and they said they would accrue to this, and we have this many participating sites. This is another study that may hit the, one of the roadblocks we've hit with one of our studies. I'll talk about that in a second, actually, but let me start talking about lung, and I'll talk about one of the challenges that we have faced there. Let's see. All right. Okay. So we've got a number of active studies in the thoracic committee that involve radiation. One of the ones that I think is really one of the most exciting studies is the 1914. So this is Megan Daly's study, which is a randomized phase 3 trial of SBRT with or without atezolizumab in stage 1 non-small cell. So, as everybody knows, a number of competing trials in this space. There's a Merck study. There is an RTOG Foundation / AstraZeneca study. One of the advantages of this study is this is neoadjuvant and adjuvant atezolizumab, so patients get, I believe, 2 cycles before SBRT. And because of that, there's no placebo arm. So the randomization is either atezolizumab or surveillance. And it's only 6 months of therapy. The Merck study is a year of therapy, and the AZ study is 2 years of therapy. So this study does have a lot to recommend it. So this is one of the studies. Megan has run into an interesting roadblock, which is that we have a lot of VAs that would really like to participate in this study. We have a lot of community sites that would like to participate in this study. But frequently, the radiation site and the infusion site are not the same SWOG site. They may both be SWOG members, but they're not registered together. And so there are a lot of barriers at the NCI to splitting a patient's treatment essentially between 2 different CTEP sites. So we're kind of escalating this through our committee chair. We've actually talked to the thoracic committee chair at NRG, Jeff Bradley, and he was very supportive. I think particularly of the VA issue, everyone feels like this is an argument that should have some traction. Anything we can do to make changes, but the changes I think would need to come at the NCI level. And I think Chelsea's trial may be another one where when we're looking at rare tumor populations, the more we can do to involve as many sites as possible, allow a patient to get SBRT in one area and chemotherapy or an infusion at another site would be very helpful. So the S1914 is open and accruing. The S1827 is a randomized phase 3 study in small cell lung cancer of PCI versus MR surveillance. It includes both limited and extensive stage. It allows the use of hippocampal sparing radiation, but does not mandate it. Actually, I think Chad Rusthoven is the PI. He did a really nice job of writing this to make it as inclusive as possible. We have a lot of international partners in this. It's accruing fairly slowly at this point. We've only got about 33 patients on it. And some of that may be due to COVID, but we're trying to address all the other concerns around this. But I would encourage everybody to consider this. The 1933 is a feasibility study of hypofractionated radiation followed by atezolizumab in stage 2 or 3 patients with borderline PS, which is to say they're not eligible for chemotherapy. The PI is Rod Ajamali, and the RT chair is Tim Mitten. I think they've only accrued 1 patient to this. This is 60 gray and 15 fractions followed by atezo. I think it's a nice regimen for patients with PS2 or other contraindications to chemoradiation. We also have a trial that's moving forward. The 1934 is a trial in superior sulcus tumors, neoadjuvant chemoradiation with or without atezolizumab. It does include surgery. Ray O is the PI. I'm the radiation chair. We actually got CTEP comments back on the protocol during the working group meeting, and they actually looked pretty reasonable, but it's 22 pages of reasonable questions, so we have a lot of work to do to answer them all. There are a couple of proposals. I'm sorry, that last one is up, but Arya is going to talk later about his, so I'm going to just skip that slide. There we go. We have a lot of study champions within the lung committee. So these are studies open by other groups. I will tell you that all of the study champions here are folks who have basically been up at the podium making trial proposals. And so, even if your trial does not get approved, if your concept, it does not get prioritized, your engagement is remembered, and we've been able to get a lot of junior mid-level investigators on board with this. This includes the LU 03, 05, 02, 06. Chad Rusthoven's going to talk about the 009 later. So anyway, we do have a lot going on in the lung committee, and trying to involve as many of our young and mid-level investigators as we can. All right, so that was my quick run through the lung committee. If there are questions, or I will try to look in the QA as well. Okay, all right. I'm not seeing anything else. All right. So moving on to the other panelists, I think I have Dr. Yu up next. If I can share my screen one more time.
I sent you way too many slides, so we don't have to go through them.
It's just your excuse to make me change slides for you.
Yeah, no, we can just go to the second slide and stop there, and I'll just go through quickly. So SWOG-GU is SWOG prostate, bladder, and renal. The most relevant studies for radiation oncologists are the ongoing ones. The first one being SWOG-1802, which is the randomized phase 3 study of standard systemic therapy with or without definitive treatment of the prostate, and that can mean radiation or surgery. I encourage the radiation oncologists to try and accrue radiation patients. I think the study is accruing well, although I think we need more radiation patients. And there's a good, there's a lot of translational medicine going on, translational studies going on. The two new studies that SWOG is championing is NRG-GU 009, which is the PREDICT-RT study. That's Paul Nguyen and Oliver Sartor's study looking at Decipher for high-risk prostate cancer. And so patients with high-risk clinical and high-risk Decipher will be randomized between standard hormonal therapy and radiation versus standard hormonal therapy, radiation, and I believe apalutamide and abiraterone. The folks with low Decipher risk will be randomized to de-escalation. So shorter course hormone therapy and radiation versus standard hormone therapy and radiation. So it's a very exciting trial. It's NRG's flagship study. I think the target accrual is over 2,000 patients. So hopefully SWOG can accrue to this. Once again, Hong Zhang from Rochester is the SWOG champion. Another study that's an NRG study that is relevant to us, the SWOG champion is Dan Lin, is NRG-GU008. That is Ron Chen's node positive study. That is abiraterone and APA as salvage therapy with radiation for node positive versus radiation and hormone therapy alone. I don't know, it's a important study in the postoperative space. And then the last study that's relevant to radiation oncologists is SWOG 1806, which is the bladder preservation study. So SWOG is doing a bladder preservation study, which is great. Chemoradiation with or without atezolizumab. The radiation oncology chair for that is Jason Estathio. And relevant to that is they don't allow hypofractionation. They do allow standard fractionation. You can treat the mini pelvis or pelvis, so it's a relatively pragmatic study. So I encourage everybody to try and enroll on that study. And then finally, renal, we don't have a radiation study. New things that we're working on in the committee are there was I think one trial slot for GU, and I think at this meeting they're going to be discussing the potential studies, but none of them involved radiotherapy. That said, I think the committee is very interested in radiation studies, or at least outwardly so. So I encourage all of you, if you're interested in specific, I think SWOG's really good at radiation versus non-radiation randomizations in GU. So please reach out to me and let me know if you have any ideas or need any help. Thanks.
Thanks, James. You want me to go through these other 12 slides, or are you good?
No, I think we're good.
Okay. All right. So thank you. Let's see. Close all these. All right. So let's see. We've got David Horowitz for GI. I don't know that David is.
Yep, I'm here.
Excellent. So let me get you rolling. All right.
All right, you can just go to the second slide. Thank you so much. So the GI committee has several studies that we're championing. I don't think that there are a lot of ones that we're leading at the moment, but the notable radiation-related studies really span the gamut from esophagus down to anus. NRG-GI006 is a randomized phase 3 trial of proton beam versus IMRT for esophageal cancer. Patients are allowed to have either resectable or unresectable disease. And so that's an important study to evaluate. Steve Lin is the PI on that one. There's an interesting oligometastatic esophageal and gastric study. So patients who have up to 3 sites of metastatic disease undergo 2 randomizations. First is to FOLFOX versus CAPOX, and then patients who have still limited metastatic disease will get a second randomization to continued chemotherapy versus SBRT to all sites of disease. And this opened right around the time of COVID and still hasn't accrued very many patients so far. So this is an important study for us to try to enroll to. The NRG-GI003 proton versus photon for hepatocellular carcinoma study is actually accruing quite well. They've accrued 53 out of 167 subjects. And then there are two high-risk anal cancer, anal cancer studies that we're championing. The first is for high-risk disease, EA2165, which is a phase 2, now phase 3 study of adjuvant nivolumab after standard chemoradiotherapy. And this is getting very close to completing accrual. They're at 317 out of 344 subjects with a primary endpoint of disease-free survival. And our anorectal group is working on a pilot for the follow-on study to this, looking at neoadjuvant chemoimmunotherapy. And that's something we've presented to the GI committee previously and are continuing to work on. And then we're also championing the DCREASE study for early stage anal cancer. This is a randomized study with co-primary endpoints of disease-free survival and then anorectal health-related quality of life, looking at decreased chemotherapy as well as radiation doses. If you could go to the next slide, I just wanted to point out the secondary analysis that Dr. Kachnik was speaking about before that we worked on with the surgery committee, and this was related to the adjuvant chemoradiation study for extrahepatic cholangiocarcinoma and gallbladder cancer, S0809, and this led to 2 abstracts for ASCO and then hopefully hear back shortly for ASTRO, evaluating the historic benefit, or the benefit of chemoradiotherapy versus historic controls in node-positive disease in particular, which showed a significant improvement in overall survival, at least the association. And then we specifically evaluated the effect of the different radiation modalities that were allowed on this study. So 3D conformal radiotherapy versus IMRT, and had some interesting findings that have bearing on prospective contour and plan review on GI studies. So with that, I'd like to turn it back to you. Thank you so much.
Thank you, David. Yeah, so these secondary analyses are great work, and Lisa mentioned them earlier. We've actually got a nice one going on. Dan Gomez is doing an image analysis on an older, completely reported trial in the thoracic group. And just as a great example, it's a trial that did not involve radiation, and he's really just analyzing whether there are predictors of kind of oligometastatic state and oligorecurrence among patients with metastatic disease. So thinking a little bit outside the box is very helpful for these secondary analyses. And you know, there's really fantastic data and a lot of resources to help you. For those of you who have a good idea, let me know, talk to the disease chair, and certainly Lisa can be instrumental in
Right, you got clicker happy again. But if anyone has an idea for a secondary analysis, please reach out. I put my email there, and I'm happy to shepherd the process.
I think my mouse is feeling very sensitive and overused today. That's all I'm going to say. Okay. Any other? We have 2 other disease liaisons, Jing Zhang and Evan Wutherick. Were not able to make it. Otherwise, I think we're going to move on to some of our speakers here today. I know I think the first that I have in my list is Tony Wang. So Tony, if you're here, I will attempt to share your slides.
So, thanks for having me. So the concept I'm presenting is a phase 2 study of atezolizumab and tocilizumab with radiotherapy in patients with newly diagnosed MGMT unmethylated glioblastoma. Next slide, please. These are my disclosures, electronically available. Next slide, please. So As many of us know, glioblastoma is the most common primary brain tumor, encompasses over 50% of primary brain tumors, malignant brain tumors. It's the most aggressive. The median overall survival, at least with the current standard of care since 2005, is about 14.6 months. And the benefit of, in that study, the benefit of temozolomide was driven mainly in the subgroup with methylated MGMT promoter, methylated MGMT. Next slide, please. So if you look at the analysis of MGMT methylation, it's essentially prognostic for median overall survival in either arm. Methylated MGMT encompasses only a third of glioblastoma patients, or newly diagnosed glioblastoma patients. And the median survival for that is 18 months, whereas the vast majority of glioblastomas are unmethylated MGMTs, and that's about 2/3 of the populations, and the median survival is about 12 months. Next slide, please. So, MGMT methylation is predictive for benefit temozolomide. If you look at the Heggie paper in the same issue as Roger Stoop, temozolomide increased the median overall survival in methylated MGMT patients by about 8 months, but in the unmethylated MGMT cohort, it was about 3 weeks actually. If you look at the data. So currently, there are a lot of interest in looking and studying particularly unmethylated MGMT population that really do far poorly with the standard of care. And a lot of the studies have really focused on the role of immunotherapy. So there's one trial that completed about a year ago with Dave Reardon in DFCI, looking at the addition of nivolumab and omitting temozolomide altogether. Portion of that study was negative. There was no increased benefit of nivolumab versus temozolomide. And there's currently an ongoing NRG BN007 looking at the addition of nivolumab and ipilimumab, again for unmethylated MGMT using CTLA-4 inhibitor. Next slide, please. So in the last couple of years, there's been a lot of interest in looking at anti-IL-6 and obviously with PD-L1 inhibitor. But in this study, which was published about 3 years ago, excuse me, this group from Northwestern looked at anti-IL-6 antibodies to see if it improves survival in orthotopic GBM murine models. You can see here in this control group, which is the blue line, the survival curve was pretty typical of median survival of 17 days. But in the combination of anti-IL-6 with or without CSF1, anti-CSF1, median survival was improved by 6 days. But again, these are all in the in vivo models. Next slide, please. So our colleagues at Northwestern, this is by Lamont et al., looked at the combination of anti-IL-6 and PD-L1 therapy. And what we found is that anti-IL-6 therapy reduces myeloid cell infiltration, as you see here in the stains, as well as increased T cell infiltration, stimulating the immune microenvironment. Next slide, please. So in this same study, so what they did was they tested these in C57BL6 mice and did a combination of anti-IL-6 and anti-PD-L1 treatments, and then followed them over time. So there were 4 arms in this study, in this animal study, which was the control group, as well as the monotherapy anti-IL-6, monotherapy anti-PD-1, and then anti-IL-6 in combination with PD-1 together. And so I'll show a blow-up slide of the survival curve, but as you can see, either by tumor volume or the specimens themselves, there was improvement with a combination of anti-IL-6 and anti-PD-1 inhibition. Next slide, please. So this was another study using
Tony, I think you muted yourself.
Oh, can you hear me?
Now we can.
Oh, sorry, I got disconnected. So, sorry, I have to answer. Can I call you back? Apologies. So this is a study using tocilizumab, which is the anti-IL-6 inhibitor, on these U251 GBM xenograft models, and it was found to help promote apoptosis in these GBM models versus the control wild type. Go next slide, please. So like I was showing you from the Northwestern study, this was the survival figure from the combination of IL-6 and anti-PD-1, or IL-6 or PD-1 monotherapy, as well as the control group isotype, which is with a survival of 19 days, versus the combination of 55 days, which is quite impressive, versus monotherapy alone. Next slide, please. So the concept I have is a phase 2 study for patients with newly diagnosed glioblastoma who undergo maximal safe resection as per standard therapy, and then to get standard radiation therapy with a combination of atezolizumab as well as tocilizumab, followed by adjuvant atezo and toci. And the doses here are actually for the toci as well is what's been FDA approved for the use of RA. And the atezo dose is also has been approved as well in other disease sites. And these are only for patients. You'll notice that I omitted standard temozolomide. The major eligibility criteria for this would be for only unmethylated MGMT patients. If you look at the STOOP study, the 1-year overall survival for these unmethylated cohorts about 50%. So our primary endpoint is to look at 1-year overall survival given the short survival period for these unmethylated MGMT patients. And our hypothesis is that the 1-year overall survival is about 7%. This will require 47 patients with a power of 80% and alpha 0.05. We expect with that sample size, it takes about approximately 18 months to accrue that much patients. And the follow-up period will also be short, again, given the unmethylated MGMT cohort of these newly diagnosed glioblastoma patients. Next slide, please.
Hi, Susan.
Hey there. I added those 3 topics to the.
So secondary endpoints is to evaluate the safety of adding atezolizumab and tocilizumab to radiotherapy. Additionally, progression-free survival. Our exploratory endpoints are to study the quality of life using quality of life questionnaires, standard indexes, to track steroid use versus overall survival. And then, other sort of future endpoints would include studying the peripheral blood immunologic profiles into relation with overall survival and toxicity, and also to look at biomarkers on these pre-treated tissues. These are the resected tissue prior to the delivery of radiation as well as immunotherapy and IL-6. Next slide, please. So, this trial design kind of mirrors ongoing and as well as completed studies. So Checkmate 498 was a negative study in newly diagnosed glioblastoma for unmethylated MGMT. And that study, it was only with nivolumab monotherapy alone without TMZ. And currently the ongoing NRG BN007 trial for newly diagnosed GBM, also with unmethylated MGMT patients. In that study, it's with nivolumab and ipilimumab. So omitting temozolomide was not a barrier to accrue patients. And we also caution using steroids only if clinically indicated, as some of the studies suggested that a higher dose of steroids was associated with a worse outcome, especially with the immunotherapy patients. Next slide, please. And like I mentioned before, this concept follows the precedent of prior unmethylated MGMT only newly diagnosed GBM patients who do not get temozolomide, no placebo, avoiding the T cell. This also avoids T cell depleting effects of temozolomide in the experimental arm, and the follow-up, again, given the unmethylated MGMT status, is short. And so, next slide, please. And so I'd like to conclude that, we've discussed this concept with the scientific team at Genentech. We're very excited. Initially, we thought of a single institution study only, but we thought it'd be great to run it at SWOG. And so with that, I don't know if there's time for questions, but happy to answer.
Thanks, Tony. I'm going to move you back to the to that. Actually, I'm gonna. All right. So I'm trying to find a way to have this presentation on my computer and look at the Q&A at the same time. So why don't I just unshare here and then we'll see if we can get that open. So do we have any comments either from someone verbally, or if you want to put it in the Q&A section. I'll ask Tony. So I know we have a CNS group at SWOG that is evolving. I'm not sure what the status is exactly of that. Lisa, maybe you can
So I'm so glad you asked that. So Manmeet, I know Chad's on the line as well. So Manmeet and I think Chad, we're having our meeting on Friday for the working group. And in terms of the concept, the people in that group are all kind of the same group of people that Energy and everyone else, like, I have them all. But so in terms of concept, there's really no competing studies. He actually has a concept being presented on Friday's meeting, but it's only with methylated MGMB patients. And the other concepts that are presented floating around are not really GBM based. And as Chad could attest to, he's got a brain met proposal, but so it's a short study. I think the sample size is short enough. It's feasible to accomplish this in the time period that we proposed.
Tony, you got a question from Tim Mitten. Is TTF included on the study? Required, permitted?
Yeah. So I think TTF is considered a standard therapy. I don't know if I require it. I think it would be dealer's choice, and I would follow the same precedent as RTOG 3508 and NRG-BN007, which did not require or mandate the use of TTF. As we know, there's that phase 3 positive trial, but a lot of patients still do not want to do it, and I think it'd be best not to require that. I would make it to the discretion of the PI. Great question.
Are there, this is Roy again, are there competing trials in other groups here or industry studies that we can be competing with?
No. So when I first pitched this with Genentech, basically they thought it was great enough to support it the way it is without any competing studies or even similar concepts, if you will. There is one atezolizumab study that's floating around with NRG, but that's in the context of recurrent glioblastomas, not stratified by MGMB status.
It seems like a great concept to me, and pretty well supported by evidence. This is a great way to kind of bring a proposal forward to the group. This is kind of what the NCTN is supposed to be all about. You're doing, and just for the group, one of the things we'd like to do is talk about the radiation trial. You're doing standard GBM radiation, I assume.
Yeah. So this would be standard 60 gray. There was a discussion I had with Manesh and Andy about elderly patients, but if you look at the current phase 3 trials for BN007 and 3508, they all still require 60 gray regardless of age.
Okay. And we've got one comment in the Q&A about if there's a young investigator who'd like to get involved in the CNS working group. So I can give the pat answer, which is that your institutional PI should write a letter nominating you to the CNS team and the CNS working group. But this is a newborn committee that's probably very small. So I don't know, Tony, if you have additional comments, or this seems like a good way to get in on the ground floor.
Yeah. As you know, Manmeet's sort of the head of that group, and I believe it's the meeting's on Friday, so I don't believe it's a closed meetings. So yeah.
Okay, so that was awesome. Yeah. So my advice usually to people is for the working group meetings, usually get the chair's permission before you show up. I think you have to with our virtual meeting to get invited, because some of them are. They're all, I think, supposed to be closed. Some are more closed than others. Any other comments, questions, anything? I'm trying to watch the chat and the QA at the same time. So, that was fantastic. So thank you, and everybody, please reach out if you have comments or questions about this afterwards. So, for the next presentation, since I see Eileen is here, maybe we'll have Eileen talk about the S2003. And again, I have your slides. We're going to give this a shot.
So I wanted, can you hear me? I wanted to give an update on my concept that's working its way through the prevention committee. This is a The original concept, which was triage approved and was presented to the NCI in February, was a non-randomized phase 2 study looking at local recurrence following intraoperative radiation for DCIS after breast conserving surgery. Our primary outcome was to look at local failure, defined as local recurrence, either invasive or non-invasive at the lumpectomy bed, calculated from day of lumpectomy to 5 years. And our hypothesis was that local recurrence rates for IORT would be better than surgery alone using a historical data set, ECOG 5194, for patients with isolated focuses of DCIS less than 2.5 centimeters in size. Next is if you advance the secondary outcomes, we had a translational medicine aim, which was going to evaluate the Decision RT score. This is a immunopathology assay which evaluates 20 different protein expression levels and is correlated to risk of local recurrence. So that was our translational medicine aim that we'd worked out. And then we also wanted to do this as a feasibility trial to investigate if there was enough patients to compare this to whole breast radiation for with DCIS, as well as collect cosmetic outcomes and physician-reported toxicity outcomes. Next slide. So background, I'm just going to be very brief to save time. We all know DCIS is a treatment challenge. The diagnosis has increased with improved imaging. And while radiation improves local recurrence, it has no impact on overall survival. So there's a concern that we're over-treating it, particularly for small unifocal lesions that are low grade. So IORT is a potential alternative, and it's become a popular option that's being offered in the community, not necessarily with data, but for early stage disease, at least the Target A trial at 5 years has shown it's to be non-inferior in invasive disease compared to whole breast irradiation. The Elliott trial, actually, the update was inferior, but they included high-risk patients. But the advantage of IORT is that it's done during surgery in patients like that. It's less toxicity as a single treatment option and has improvement in quality of life because you're avoiding the inconvenience of external beam radiation. So, and it is, DCIS was added to the ASTRO APBI guidelines for treatment options, though IORT was listed as only on a clinical trial. So next slide, the study as it was initially designed was a single arm trial where we initially pre-screened patients who would be 40 or older, screen detected tumors less than 2.5 centimeters at grade 1 or 2, less than 1 centimeter at grade 3, unifocal, operable. All patients would get surgery and radiation. Post-op, you would risk stratify based on post-operative features. And if they still remain suitable or cautionary, they would be included in our long-term local recurrence outcome. If high-risk features such as grade larger than 2.5 centimeters in size, or if invasive disease or positive margins were found, then they would be put into an unsuitable or high-risk group where whole breast irradiation would be recommended, not necessarily required, and they would not be looked at for the primary outcome, though we would include them for cosmetic outcome. So the primary outcome was local recurrence, as I already stated. The IORT was going to be inclusive of either the Zoft or Zeitz low energy X-ray systems, not including electrons, so excluding the Elliott option. Post-op task would determine risk stratification, and if whole breast irradiation was recommended, it would be given 8 to 12 weeks later, 40 gray and 3-week fractionation. And we would prospectively collect FFP pathology blocks from the biopsy and lumpectomy for inclusion in the translational medicine aim. So next slide. So this next slide shows the history of this. So this concept was triage approved in October of 2019. I was able to obtain support from industry, both Prelude DX, which does the Decision RT score test. They were willing to support the translational aim. Zeiss and Zoff were supportive of helping support the trial. The translational medicine proposal was approved in May of last year. Statistical review was completed in May at the same time, and we went through feasibility, financial feasibility, We spent a few months working with IROC to determine credentialing for our IORT because that has not been standardized, so that was also worked out. We presented it to DCP in February of 2021, and unfortunately it was disapproved. So the next slide goes through their concerns. So their biggest concern was they did not like a single arm non-randomized trial design. That was not something that they were interested in doing. The reason we had chosen that originally was because it allowed us to have a smaller number of patients to answer the study question and include both an intermediate and a low risk cohort. But they really did not like that because they're concerned that the historical data may not be reflective of the outcomes that you would expect now with better imaging. They also did not like the inclusion of more intermediate or cautionary risk patients, essentially the age 40 to 50 group with grade 3 DCIS or ERPR negative DCIS. And this is based on unpublished data from NSABP V39, which I was told that the hormone receptor negative group actually did inferior with DCIS. So they didn't want that cohort included, but that's a minor modification. They didn't like that we didn't stratify whether patients, or randomize whether patients took endocrine therapy. I mean, I think our plan was to stratify. I don't think you can require it. That was after a lot of review by several. I mean, I think it's difficult to get patients to take hormonal therapy. So I'll get to it, but we're not changing this, but we would plan to stratify based on use, like record whether patients are using it and whether they're compliant, but not require it. And then we would change, they didn't like that the primary endpoint was local recurrence in the tumor bed. They would rather keep it consistent with all the earlier trials of any in-breast tumor recurrence. Other issues was because we included an intermediate group where a higher percent could potentially become high risk post-op, which meant about 20 to 30% of patients would get offered additional radiation. They wanted us to lower that percentage, essentially keep this to a narrow focus of patients, lower risk. They wanted a direct comparison of IORT to surgery alone. That came out in the letter multiple times. And then they wanted to prospectively validate DecisionRT with surgery alone. So they felt like not including that arm was a missed opportunity. And there's some concern that this overlaps with the COMET trial. However, that is an observation trial. This study is for patients who want to get surgery. So I think that they're two separate cohorts of patients because a patient who wants surgery isn't going to be interested in the COMET trial. And then they did not like 5-year follow-up. They really felt that we should do a 10-year follow-up timeline. So taking all of this into consideration, the next slide shows the revised concept that's been discussed in the prevention committee, and I wanted to bring forward to the radiation committee for comments. So essentially, they really want us to focus on the lowest risk patients based on their preoperative risk data. So this is 50 and older, must again be screen detected unifocal, 2.5 centimeters, less than 2.5 centimeters in size, but restricting to grade 1 or 2 and ER positive. That's the main difference, is really keeping it to the lowest risk group. And now randomizing them to surgery alone versus surgery plus intraoperative radiation. And just prove whether or not intraop is doing anything at all. I think that's fundamentally the biggest controversy in the field with intraoperative radiation, is that there's a lot of people who don't think that it's adding significantly to surgery alone, and this would be a way for us to see if it is effective. So our primary outcome would be local recurrence, as in any in-breast tumor recurrence at 10 years. We would again, hormonal therapy would be offered. I don't think you can require it because many patients will refuse to enroll in a study that requires them to take hormonal therapy. But it is going to be recommended, and we plan to record whether they accepted it and whether they were able to stay on it for the recommended time. DecisionRT would still be included for all patients, but again, because we want to not have it change treatment management, it would not, the score would not be provided to the patients. We would just use this to prospectively validate that it is accurate in predicting people who don't need radiation. So all patients would be suitable risk preoperatively. This is a risk adapted study though. Postoperatively, 10%, even in this low risk cohort, might have features which make them higher risk, either cautionary by APBI guidelines or unsuitable. This would be, we find grade 3 disease. It's bigger than 3 centimeters, 2.5 centimeters in size. The margins are positive and it requires re-resection, or we find invasive disease. So again, whole breast irradiation would be offered. It's not required because some patients are not going to necessarily accept that, but we would want to follow this, and it would be again 40 and 15. But the change here is that all patients would be kept on the study, so it's risk adapted, and I'll get into the statistics, but the idea is that we would power this to have enough patients to demonstrate on the groups that only got IRT or surgery alone that whether there is a benefit, but we'd include the patients who got additional therapy so that we can look at the increased toxicity caused by having both IRT and whole breast irradiation. So having both an intention to treat and what they actually received. Hormonal therapy based on literature review and experience, we expect between 50 and 70% of the patients will actually accept it and complete it. Decision RT will still be planned, but it won't be reported to the patients. We'll just analyze it after completion of the study. Next slide is the statistics. So here the assumption, now this is where we need feedback because there's a little bit of debate based on earlier trials, and I flip-flop the tamoxifen usage here, what the expected local recurrence rate would be with surgery alone. The ECOG trial for the same low-risk cohort at 10 years reported local failure. This is cohort 1, the yellow line, was 12%. And that was 30% of patients used tamoxifen. I switched the numbers, sorry about that. And whereas RTOG 9804, which was randomizing low-risk patients to either surgery alone versus whole breast irradiation, 70% of patients used tamoxifen, and they had a 10-year local recurrence rate of 9%. Given that RTOG 9804 initially required tamoxifen, it's thought that this is a higher rate of tamoxifen use than what we would actually see. So our question is whether we should do, a local recurrence rate at 10 years of 12% might be too high because we're probably going to get a better usage of tamoxifen or arimidex than the E5194. 10% is sort of what I'm leaning towards. This means that we would require 678 patients because essentially that's adding an additional 10% patients for loss to follow-up as well as 10% additional for risk groups change, meaning that we want to have enough in the end who got surgery only or surgery plus IRT, excluding whole breast irradiation to answer the question, but then we would report the entire cohort, those that got both as well. And this is with 80% statistical power with a one-sided alpha. So that's the new design that we're rewriting the concept to bring back to DCP. So next slide I would really appreciate feedback, comments from the group.
I think that this addresses a lot of the DCP's comments, and they always like a nice, neat trial and question, which this is, albeit more patients. I think you have on your survey data proof that even these numbers are feasible from all the centers that do IMRT with either of these devices. I guess my only comment, which has nothing to do with your design, but just with the logistics, and maybe Rashma can help on that. So would it be now that you have to take this to the breast committee and it's going to go through CTEP and not DCP because now you have a 10-year local recurrence primary? Your last one was more feasibility and a kind of cancer care delivery, but now you're actually having a randomized question with an outcome.
I mean, the prevention committee seems to think it could stay there. We may need to present it to the breast committee. I don't know, Rashma.
Yeah, I think that's right. I think it's worth trying to stick with DCP, and they have, for example, for the randomized trial that Alliance is doing of fractionation for patients who've had reconstruction. That one went through DCP, and so I think, given I just want to say hats off to you, Eileen. You have done such incredible work here. I mean, it's really incredible to get the device manufacturers on board, to get the genomic testing company on board, to create your own credentialing. I mean, you've pushed this boulder all the way up the mountain, and it is extraordinary. DCP, you've addressed their comments. I have to say, having seen it from years ago when you started thinking about this. I'm so excited about this final design, though. I think you've shown it's feasible, and I think you're going to answer the really important questions. So it actually has created something good, as miserable as it appears to have been. I think you should try to stick with DCP if you can, because like starting with CTEP will be painful. I do suspect you'll have to like get some generalized blessing of maybe bold and steering committee. I don't know, but I actually think you're doing what they wanted in the first place. Now you're focused on the low risk group, you're randomized. I think it'll fly.
Yeah, I mean, the one feedback that was interesting is they said that too many of the sites in the survey that I submitted letters were academic. So I don't know how to address that. They said, oh, there's not enough community sites. And I was like, understand. So I don't know if you.
That's hard. That was DCP.
Yeah. You have all the hippocampal avoidance trials that had 20% encore accrual, which we thought was a big win anyway. So I think if you have some major sites that are community-ish that do IRT, and I know there are, you just need to then maybe break that out in your next version.
Okay, yeah, I think that's what I'll highlight is there's a few really community, like Kaiser is on board.
Yeah.
Yeah, it's framing. I think it's just going to be framing.
Okay.
I agree, Eileen. You've done a really fantastic job of sticking with this, and I think ultimately this looks like a great trial that I think will answer an important question, and that's what you can really ask for. So, nice work. Good luck. Let us know what we can do to help.
Okay.
All right. Thank you. Next, I think if Arya Amini has signed in, he told me he was on his way.
Yeah, sorry about that. I'm here.
All right, so you're on.
All right. I even told him to block clinic, but I need to next time travel outside of the state, just somewhere, so they don't.
Yes.
So thank you. Apologize again. Do you want me to pull up my slides?
I think I've got them. Do I have them up? Oh no, I didn't share. Sorry. I will pull these up. So just as a matter of introduction, Arya has presented an oligoprogression study to the lung committee, and I kind of got there was enthusiasm, but there was also so many comments about different directions that it should go that it was a little bit of a non-starter. The lung committee has one more slot right now, so I think Arya's kind of looking to get a lot of opinions on what direction he should go here. Does that summarize it, Arya?
Yes, and full on honesty is good. I think there's a lot of great ideas out there. So if this is one that people don't feel is appropriate for SWOG, please let me know. I think it's well, thank you, Roy. Thanks for the introduction, and thank you, everybody. I'm a radiation oncologist out at City of Hope, and one of the areas I think a lot of our excitement is in these patients with oligo-progressive non-small cell lung cancer, where there's a little bit less data for, but we've extrapolated. And I got interested in this topic because most of my patients are actually not the ones that present with oligometastatic disease or get 2 to 3 months of therapy, and then we consolidate the oligometastatic sites or enroll on the NRG-LE002 study. Most of the patients I see here a lot, and maybe the practice patterns are different, are these patients that are on an EGFR inhibitor or on PD-1 inhibitor that are on for their treatment for a year and are progressing in a few sites, and the medical oncologist who's happy overall that the disease is controlled has a few areas that are growing, and so we radiate, and sometimes we look great because then the patient continues, and then sometimes it 3 months later areas progress, and so this led me to get, and I know there's a number of studies like this in single institution studies we can touch on, but I wanted to propose this at a cooperative level, and I thought this would be a great one for the SWOG group to consider. So we can go to the next slide. I kind of basically touched on the background already, but there's a lot of the definition here for oligoprogression, and I think most of you, if not all of you, know this already, so sorry for extra wording here, but the idea here is this is limited tumor progression in patients that otherwise have well-controlled widespread metastatic disease that are doing well on their systemic therapy, but just have a few sites that are growing. And instead of potentially switching to the next standard of care option, would consider doing something local to prolong that current therapy. And so that's at least the idea behind this. There's a little bit more limited data in the oligoprogressive setting. We have a good amount of data in the more upfront oligometastatic setting. And so that's what spearheaded this project. We can go to the next slide. So our hypothesis is that in patients with non-small cell lung cancer, the addition of SBRT to oligoprogressive disease, which we consider 1 to 5 sites with continuation of that current systemic therapy that they're on, would lead to an improvement in progression-free survival and overall survival compared to the standard of care systemic therapy arm. And I'll go into this in a little bit more detail. So you can go to the next slide. And so these are the 2 study arms. The standard of care arm is really, it's at the discretion of the tumor board and the medical oncologist, and that's where patients are progressing. This arm would be no local therapy, and they would either begin the next systemic therapy, the next line systemic therapy, or if the medical oncologist felt they should just continue their current systemic therapy, they could do that too. This would be at the discretion of the medical oncologist, but no local therapy for this patient, for this arm. And the experimental arm would be doing SBRT to those 1 to 5 sites that are actually progressing, and then continuing on that current systemic therapy that they're on. So you can go to the next slide. And so, sorry, it's a little bit wordy, but I'll summarize. So these were the inclusion criteria, and I'm kind of gone back and forth and looked at other studies that have done similar, sort of modeled similarly too. And so this is sort of the inclusion criteria I came up with several other people on this call too that have really been helpful in this process. So it'd be non-small cell lung cancer patients, 1 to 5 sites that are progressing on first-line systemic therapy for at least 6 months. So this is variable, but the idea here was that a patient would be on that first-line therapy for at least 6 months before they're found to actually progress. And then they would have some documentation of progression, and I have a slide on that, on how we define progression. These would all have to be treatable with radiation with SBRT, so they'd be evaluated by a radiation oncologist. The oligoprogression would happen either, and this is also another, and I'll have all these questions at the end for people for the discussion, but I wanted to include, and this was part of the group discussion with a few on this call too, EGFR positive patients, negative patients. It can muddy it a little bit, but I think it would be interesting to answer both. So it would be patients on immune checkpoint inhibitor with or without chemo or TKI. The primary tumor should be controlled, and if the primary tumor actually is one that's progressing as well, I had thought of considering that as one of the oligoprogressive sites, and it would be treated as well. Brain mets would not be an exclusion, but would be treated, and that would not be considered a site of oligoprogression. They would just be treated with, SRS or whole brain, whatever the team decides. And then the ECOG status, I kept it pretty open to 3 or less, because in general, I think a lot of these patients, even with poor ECOG status, are on a checkpoint inhibitor and can tolerate SBRT. And then patients that had prior metastases treated before this, say they presented up front with a painful bone met, could still enroll on the study if they have oligoprogression. So next slide. And so I won't spend too much time on this because this is pretty straightforward, but this is the criteria for progression. So we would use RECIST. We'd also potentially could use PET imaging for this, and or 2 scans showing clear progression with at least 5 millimeters. And this was just on a literature search on the different definitions that we use currently for progression. This is open for, we can always modify this in the future, so I didn't want to spend too much time, but this is based on the standard guidelines that document progression right now for radiology. So we can go to the next slide. And so the endpoints, which we've had a discussion on another trial, and I know endpoints are always critical. The 2 endpoints I and the group liked was, my few colleagues on this call liked, was progression-free survival and overall survival. I think A lot of us will like the endpoint of overall survival. It requires a little bit more in patient number, but I think that's probably the nicest endpoint, but progression-free survival is a common endpoint used in a study like this. Secondary endpoints would be quality of life, grade 3 or higher toxicity, local control, and just general patterns of failure. The time to the next systemic therapy, I think for both arms, but specifically for the SBRT arm. And then looking at biomarkers, including circulating tumor DNA, to better predict who are those patients that will respond versus the ones that maybe will progress rapidly and should be getting next line systemic therapy. And then looking at imaging, and I know we've done a number of this, but I think using the imaging that we get to assess response, these patients will be on a TKI or a checkpoint inhibitor. So I think there'll be some novelty there and data to do some secondary analyses. So next slide. And so this is the study schema. I think my next slide after this will go into the statistics, and so I'm almost done. But this is the general summary that this is oligoprogressive disease. They're progressing on first-line systemic therapy, 1 to 5 sites. All sites are amenable to SBRT. If the primary is progressing, and that would be included as one site and treated, but you don't have to treat the primary if it's stable. You don't have to treat all the initial metastatic sites. So I bring that up because that came up and we can talk about it too. But a patient that presents a year before with 20 metastases would still qualify as long as they have anywhere from 1 to 5 metastatic sites that are progressing. So it's really trying to evaluate the role of local ablative therapy at the point of oligoprogression. And that's why I think it's reasonable to keep patients that present with 2 metastases at initial presentation versus 20. And then they'd be stratified with 1 to 3 versus 4 to 5 sites. And then if the group feels comfortable including all non-small cell lung cancer patients, I think the EGFR, we would stratify by EGFR as well. And the 2 arms are highlighted. It would be SBRT versus standard of care, which would be systemic therapy alone at the discretion of the medical oncologist. And so we can go to the next slide, I think, and then we'll come back and maybe sit on this one. But these are the statistical design. We thought either a 1-to-1, and I've sat with our statistician, a 1-to-1 design or a 2-to-1 trial design to accrue faster. Sample size, when we did our calculations, and this is for a phase 2 trial, and one of the questions would be, are people comfortable even just going forward with a phase 3? But sample size was actually reasonable. It was around 80 to 100 patients. Or at least I thought was reasonable, 80 to 100 patients for a group where we're just looking at our EGFR wild type patients. But if we're including everybody, including EGFR mutant patients, then that stratification will require more patients. And so we're talking around 100 to 120 patients to power a study like this. I think my final slide are questions. Sorry, one more slide. So these, I did a search, and there may be more, but I spent a few hours trying to look. There are a few sites that are doing single institution similar studies. These are a few that are small studies trying to answer this, and it's a little bit wordy, but the Canadian group is doing a similar study using standard of care versus SBRT, similar primary endpoints. I think I lost a little dash, but the Wake Forest group is doing it as well. And sorry, this slide kind of messed up a little bit, but Wake Forest has a phase 2 study. Belgium also has a single arm study with EGFR, looking at EGFR positive patients taking Tagrisso with SBRT, just to look at duration of response. MSK has a study looking at breast and lung cancer patients. The China study is not open yet, but it's on clinicaltrials.gov with a similar idea looking at PD-1 inhibitor plus radiation, and that's a single arm study as well. And then I thought the Switzerland group was interesting. It's doing atezo plus 8-gray to oligoprogressive sites, and that's a single arm study. So my last slide just has questions, and I can stop on that. And if the group wants, we can go back on that slide, the study scheme. But I thank you all for your time and appreciate all the comments and feedback and honesty, but not too honest.
Comments?
Roy, and you know the thoracic landscape quite well, SWOG and beyond. What do you think the chances are in terms of the priorities? What's coming down the pike? Or will you know more after your lung cancer committee meeting later this week?
So I know there is an alliance study that is kind of in this space, but I don't honestly know the details of it off the top of my head. Do you, Aria?
I know of, if it's the same one, there's one study with the non-small cell PD-L1 0% getting, I believe, Ipi-Nivo and SBRT to one site. And I think that's more in the upfront setting, unless there's another.
Yeah, there's not a lot in lung cancer in oligo progression, and I mean, I think that is a good area to aim at, but honestly, I find it a very difficult. There's a lot. It raises a lot of questions because everybody has very different ideas about what the right thing to do is, right? You know, so half the room wants to continue the same therapy, but then of course you can't do that if you're randomizing to not getting SBRT. And one of the major concerns of the thoracic committee is always competing studies. We've had a lot of trials get rejected by the NSAID because there's a competing study. And depending on how you present this, someone could argue that this competes with literally everything. I mean, I would argue that this could be kind of worked in you know, in some way, shape, or form, you know, between other studies, because you know, you have an opportunity to kind of oligo progress, you know, rescue those patients, and if they fail, go on to the next study. I think my one recommendation is that I think the inclusion does have to be fairly narrow. I think you're going to get a lot of criticism for throwing in EGFR mutant, EGFR wild type immunotherapy. You might just want to look at patients who are failing, you know, first line immune therapy, or who are failing first line chemoimmune therapy, or even limited to EGFR positive. Although there's been a few of those EGFR positive studies, at least smaller ones out there. And you know, as it's written, as I understand it, right, it's basically dealer's choice of next systemic therapy. And I do think that's the right thing to do, but I think it's also a little bit of a hard sell to the group, right? Everybody likes to think that you should combine this with some other exciting idea, and then you really don't answer any questions at all. I don't know. What do people think? You know, what's the level of enthusiasm for an oligo progression study? And so I'm trying to catch up on the comments here.
We have a comment from our esteemed past chair of this committee, and I concur with him. We are doing this in practice, but it would be nice to actually prove that this has an impact on survival. I think, Roy, you made some great comments on trying to make the eligibility a little tighter, a little more homogeneous. And I think considering, you know, is it going to be feasible? Considering a 2-to-1 randomization with 2 as the study arm would be helpful. And I know I need to answer a phone call, but.
Yeah, and I think the benefit of a narrower eligibility is to basically say that we're not really competing with anything at this point, right? That these patients could then go on to the next thing. You know, you don't want to compete with lung map because obviously that's the kind of the jewel of the committee there, and that's second line therapy there. So you had to figure out the space around that. I think ultimately either PFS or OS need to be your endpoint. I think responses, I don't think anybody really cares. I think, you know, if we don't show at least a PFS difference, I don't think it's going to go anywhere.
We have another comment from Dr. Perez. What about focusing on a particular mutation group other than EGFR? So not lung, but an actual mutation.
Yeah, I think, I mean, are there anything in particular? I think it's a
Brett,
good
do you wanna comment? I don't have to, we've gotten to be a smaller group over the hour and a half, so.
It's a little difficult to release people.
Oh, yeah, he can't speak. Sorry.
Yeah.
He's saying like the match try.
I just gave Brad the ability to speak.
Oh,
All right,
thank you.
Brad. Now you have to say something witty.
Can you guys hear me now?
Yeah.
Okay, great. Okay, thank you very much. So, no, I think this is a really, really interesting concept, and I do agree that, many people are already treating these patients in practice. So, equipoise for randomization may be an issue with the particular design in small cell lung cancer, and especially with EGFR mutant non-small cell lung cancer. But, I do think, just trying to be just innovative about trial designs, and since this is not a disease-specific group that we're in here necessarily, would there be an opportunity to, pick a different mutational cohort that could be identified in patients that are progressing on first-line therapy with, let's say, an ALK-directed drug to be randomized to the next generation ALK drug versus continuing the current ALK therapy with radiation, and be more focused about what the two arms are as well in terms of the therapies.
Yes. So one of the benefits there, if you do a little bit of a dealer's choice, would be to allow the investigator to even continue the existing therapy, right? If you have someone who has kind of slow progression, they might be willing to try that.
Yeah. No, and for this, the standard of care, I modified it a little bit from my initial presentation that you could still, if the medical oncologist, if it's minimal progression, but it qualifies for progression, but they want to stay on that same drug, they can. So they're not required on the trial to switch to second line therapy. They can stay on the same therapy, even if they don't get radiation.
But I mean, at that point, isn't that a really different group of patients? Like, they're staying on the same therapy that's not working versus a group of patients that's trying something different. Like, they're not really the same arm anymore.
Right. I'm trying to think. Meaning I guess, yeah, I mean, they're technically going two different directions. And I think the question is whether even doing radiation, I mean, we do it, I do it, and I believe in it, I'll be honest, but I don't know if I'm helping people live longer by doing that. We think we are because they're continuing on that therapy and then maybe progressing 6 months later and then going on their next line. So that hopefully would buy them more time. But I get your point, though.
Yeah, and I think I'll make a comment. So some of the more interesting ideas I've heard in the targeted therapy space would be kind of upfront first line. So someone who presents with, an ALK rearranged lung cancer and has less than 5 sites getting randomized to radiation or not, with a PFS or OS endpoint. So those are nice, clean studies that I think could be done. But in the oligo progression, it's kind of hard, right? You can do a single arm study and keep them on the same drug, or you have to switch them, and it gets tricky fast. Okay. Any other comments for Arya? Yeah, so we've got one slot left in the thoracic committee for the next couple of months. So we're gonna have to fight for it, I think, Arya.
Okay. I'll try.
All right. So let's go. So I think our last speaker is Chad Rusthoven. Chad, being an overachiever, is presenting several studies. And I think there you go, Chad. You're up.
Thank you, Roy, and thank you, Lisa, for the opportunity. So I'm going to be presenting 4 studies and trying to go kind of quickly. They're all studies that are now open. One of them is led by SWOG with me as the PI, and then the other 3 are studies that are being championed in SWOG. So this study's been presented here before, but just a reminder that this study is open, and we would invite you to please consider opening it and enrolling patients on it at your center. This is the SWOG S1827 Maverick trial, and this is MRI surveillance plus or minus PCI for patients with limited and extensive stage small cell. Next slide. So brief background, PCI its well-known effect is to reduce brain metastases. There were a number of high-profile studies that suggested an improvement in overall survival. These studies were limited by heterogeneous and often absent brain staging and surveillance. To address this, there was a randomized trial that was done in Japan that enrolled patients with extensive stage disease only. And it was a randomized trial of MRI surveillance plus or minus PCI. And in the context of that comparison, there didn't appear to be an overall survival benefit. PCI still reduced brain metastases, but the results of that trial suggested that they may be salvageable in the context of close MRI surveillance. Next slide. So here are the NCCN guidelines just to review. So for limited stage, PCI is still a Category 1 recommendation. For extensive stage, PCI is a standard option that's left to the discretion of the treating physician, and all patients are recommended to have MRI surveillance Q3 to 4 months during year 1 and Q6 months during year 2. So just to remind, the Japanese study only included extensive stage, and so now we have conflicting data from the EORTC trial and the Japanese trial regarding overall survival benefits with PCI and extensive stage. But for limited stage, it's still a Category 1. The Operin meta-analysis in the New England Journal from 1999 is still the gold standard data that suggested a survival benefit. Next slide. So that brings us to the schema. So this is the Maverick trial. And so this is a phase 3 trial of MRI surveillance plus or minus PCI for both limited and extensive stage small cell lung cancer. It's a very simple randomization, a very pragmatic study design. Patients are randomized 1-to-1 to PCI versus no PCI, and then all patients have brain MRI surveillance on the same schedule as the Japanese trial and as recommended by the NCCN guidelines. The primary endpoint is overall survival with the hypothesis that in the context of MRI surveillance that there will be no difference in survival between the arms. As I said, the study is very pragmatic. Any and all standard first-line therapy approaches are acceptable, and patients can go on the study really in any way that they're treated prior to randomization. The study also allows hippocampal avoidance PCI. That's the topic of an ongoing NRG study, and there is data that supports hippocampal avoidance in the context of whole brain radiation. As people are aware. So some centers are already using hippocampal avoidance PCI. We track that prospectively, and we'll do subset analyses with that information. We also allow salvage radiosurgery. Immunotherapy is also allowed. Next slide. So this is a study that's open across the NCTN throughout the cooperative groups as well as Canada. We also have a VA champion, so we're really trying to cast a wide net. Because it's a very important question, but it also takes a lot of patience to answer this question. We have the study open at over 200 sites. Our accrual has been slower than expected. We're actually at 35 as of today. There are a number of reasons for this that we can postulate. COVID has obviously caused disruptions. There are some competing trials in the limited and extensive stage space. And it's a little bit of a challenging randomization. I can speak to this myself. We actually just randomized a patient today to this trial, and I think I've learned a few things as I've presented this to different patients along the way. I think framing this question is really important. It's important to communicate where the data lies for patients, that PCI is a Category 1 recommendation, and that this study, the experimental arm in this study is MRI surveillance alone, and that the best data that we have still suggests that there's an overall survival benefit for limited stage patients. And then it's also important to note that PCI always reduces brain metastases, and that's a very important thing to many patients, and it's important to mention that. We get sometimes we focus on the potential cognitive and quality of life issues, and those are important too, obviously. That's why we're doing the study. But it's also important to talk about the benefits because there's a reason why PCI became the standard of care. And just overall, the MRI surveillance alone arm is really the experimental arm of this trial. And then again, as mentioned, it's a very pragmatic design that is very welcoming to accrual. We also have a baseline approach to want to allow dual enrollments where possible because there are some other exciting trials that are going on in this space with emerging therapies. And just another plug that the hippocampal avoidance PCI and memantine are allowed at physician discretion. Next slide. Okay, so that takes me to another study that recently opened, and I've had the privilege of working with a great group from the NRG side with this study, including Dr. Vinay Gandhi and some other people listed here. This is NRG CC009, and this is a phase 3 trial also in small cell lung cancer, but looking specifically at patients who already have brain metastases. And it's a randomized trial comparing radiosurgery versus hippocampal avoidant whole brain radiation. Next slide. So brief background, for small cell lung cancer, whole brain radiation is still the standard of care whether you have one or more brain metastases. And the reason for this is that there's many layers to it, but it boils down to the fact that prior brain metastases randomized trials that have looked at radiosurgery alone have excluded patients with small cell lung cancer. And there's been concern in patients with small cell lung cancer specifically that these patients might be at risk for short interval CNS progression. You could miss your opportunity to offer salvage therapy, and this could lead to a decrease in overall survival in some small cell lung cancer patients. And so people have been less comfortable with offering radiosurgery and withholding whole brain radiation in this population. However, as we know, whole brain radiation does come with some potential side effects in terms of cognition and quality of life. In general, there's a number of strategies to mitigate this, including radiosurgery alone, also the addition of memantine, hippocampal avoidance, and then some emerging systemic therapy alone strategies. Next slide. One of the problems with radiosurgery in this space is that there hasn't really been good data, even retrospectively, to support what the outcomes could be with radiosurgery alone for small cell, and to suggest that it may be safe in some populations. And so I had the privilege of working on this study with some international collaborators that we published last year. We gave it a fancy name, the FIRE SCLC cohort study. And basically what this was an international retrospective study across 3 continents, and we pooled together as many patients as we could treated with upfront radiosurgery for small cell brain mets without prior PCI or whole brain radiation. And then we did a matched analysis comparing that data with patients who were treated with the standard of upfront whole brain radiation. And what we found was, as expected, whole brain was associated with better CNS control, but we did not find that whole brain was associated with better overall survival. In fact, there was a little bit of a trend towards better survival with the radiosurgery arm, but it's a retrospective, so we didn't want to overinterpret that. But overall, we would say that these outcomes look fairly similar to what we see with comparisons of radiosurgery and whole brain in other populations. Some other interesting things were that those who did require salvage therapy, the majority could be treated with salvage radiosurgery, and the rates of concerning outcomes like leptomeningeal progression and neurologic mortality were low in that group. Next slide. There's also been some important practice-changing data in the cooperative groups in the randomized setting, trying to improve on the toxicity with standard whole brain. And so here's just some important slides from 2 such trials. RTOG 0614 showed that the addition of memantine was associated with better cognitive outcomes. And then more recently, the NRG CC001 showed that the addition of hippocampal avoidance in comparison to standard whole brain was also associated with better cognitive outcomes. Next slide. So that brings us to the schema slide. So again, this is NRG CC009. This is a phase 3 trial of stereotactic radiosurgery versus hippocampal avoidant whole brain radiation for patients with 10 or fewer brain metastases from small cell lung cancer. It was activated at the end of February. So we're very excited. We're kind of in the local site ramp-up phase. So if this study looks interesting to you, we'd love to invite you to open it. And please feel free to reach out to me if you have any questions about it. So basic eligibility, small cell lung cancer patients, 10 or fewer brain mets. We have some volume criteria, and performance status of 70 or greater. Patients are then randomized in a pretty straightforward fashion to radiosurgery or hippocampal avoidant whole brain radiation, 30 gray and 10 fractions. The primary endpoint of this study is time to cognitive failure, and the statistics are that we hypothesize that stereotactic radiosurgery will result in improved cognitive outcomes for patients, and the study requires 200 patients. One of the other underlying assumptions is that there'll be no difference in overall survival, but we'll certainly look at that as well. Next slide. So moving on to two other studies that SWOG is now championing through the emerging CNS working group that Roy and Tony were mentioning before, that's led by Dr. Ahluwalia. So this is Alliance 071801. This is Paul Brown's study. It's a radiation trial looking at patients with brain metastases that have undergone surgical resection and then randomizing them to either single fraction or multi-fraction post-op radiosurgery to the cavity. Next slide. So brief background for this study. So after surgical resection, post-op radiosurgery is now considered an acceptable standard based on several randomized trials that were published in the last few years showing better local control with the addition of radiosurgery versus observation. And then when radiosurgery was compared to whole brain radiation, as expected, radiosurgery was associated with better cognitive preservation. However, it's not a perfect treatment, at least in the single fraction form. These studies showed that the single fraction post-op radiosurgery local control outcomes appear to be suboptimal in these prospective trials, with 1-year local control rates of about 60 to 80%. And then meanwhile, there have been some non-randomized retrospective data and some single-arm prospective trials that have suggested that multi-fraction radiosurgery might be a better way to go, and the outcomes for local control are higher where we'd expect in that 80 to 95% range. So this trial is a phase 3 randomized trial of single versus multi-fraction radiosurgery to the postoperative cavity with a primary endpoint of surgical bed control. Next slide. So here's the schema. So this is for patients with brain metastasis. There are some size criteria. The brain metastasis had to be over 2 centimeters, and then the cavity less than 5 centimeters that you're treating after the surgery. Here are the stratification factors, and then patients are randomized to single fraction radiosurgery or multi-fraction radiosurgery. And it's either a 3 versus 5 fraction radiosurgery treatment based on the size of the cavity. And again, the primary endpoint of this study is time to surgical bed recurrence. Next slide. So here are the key inclusion criteria: status post resection of a lesion that's greater than 2 centimeters, and then the post-op cavity has to be less than 5. They have to have 0 to 3 unresected lesions, each less than 4 centimeters in addition, that would also be treated with radiosurgery at the time of treatment. Performance status 0 to 2, fluent in English, Spanish, or French. Exclusion criteria include whole brain radiation, inability to have MRIs, chemotherapy during the radiosurgery, and then brain metastases that are close to the optic chiasm or brainstem. Next slide. So this study was activated in October of 2019. It has a target accrual of just over 200 patients, and it's actually accruing extremely well. I just checked this morning, and it's now up to 94 patients, so it's almost halfway accrued, and it's been endorsed by the SWOG CNS working group as of February 2021. So this is a nice study to participate in. It looks like it's going to accrue successfully, and it's asking a good, straightforward question, and hopefully it'll provide some good data on how to best manage these patients. Next slide. And that leads us to the last trial for me to present here. So this is NRG-BN009. And so this is an interesting study kind of testing a novel concept. So this is a phase 3 trial of salvage radiosurgery versus radiosurgery plus hippocampal avoidant whole brain radiation. So the question is the addition of the whole brain radiation for this group in patients on their first or second distant relapse after prior SRS with a brain metastasis velocity of greater than 4 mets per year. And this is a study that's being led by Dr. Gandhi as well as Mike Chan from Wake Forest. And I'll go into this and try to make this randomization more clear on the subsequent slides. Next. So some are probably familiar with this concept of brain metastasis velocity. There's been a number of papers that have kind of fleshed out this concept. Basically, large retrospective series have suggested that after patients receive radiosurgery, that how quickly they develop brain metastases thereafter is a good predictor of overall survival as well as neurologic mortality. And so here's just presenting some slides from some of these studies. On the left, we have overall survival. On the right, we have neurologic mortality. And they're stratified by a brain metastasis velocity of 4, 4 to 13, and greater than 13. And the way that you come up with that number is basically number of brain metastases developed divided by year. So if you develop 4 brain metastases in 1 year after you have radiosurgery, then your brain metastasis velocity is 4. If you develop 4 brain metastases in 6 months, then your brain metastasis velocity is 8. And so on. It's a pretty straightforward formula. But basically, when you look at how quickly patients are developing new brain metastases, it's associated with outcomes. And so the question is this predictive of benefit from more aggressive therapy? Are these patients who we should actually consider offering whole brain radiation? Even if it doesn't improve survival, could that reduce neurologic cause mortality? And that's the fundamental question of this study. Next slide. So here's the schema. Again, this is a phase 3 trial. It's looking at patients who have had prior radiosurgery and are on their first or second distant relapse after radiosurgery with a brain metastasis velocity of greater than or equal to 4 per year, and they're being randomized to radiosurgery versus radiosurgery plus hippocampal avoidant whole brain radiation. The primary endpoint of this study is time to neurological death, and the investigators have been very rigorous about how they define that. There's a very clear discussion of this in the protocol, and then some forms that are filled out by investigators that ask general questions about what was going on at the time of death. And then those forms are actually reviewed in a blinded fashion by some of the study chairs, including a neurological oncologist, to define which patients actually develop neurological mortality. And they'll look at other standard things too, like progression-free survival, overall survival, and cumulative incidence of recurrences, and quality of life and cognition as well. Next slide. So here are the key inclusion criteria. Again, patients have had prior radiosurgery, so this is not in the upfront setting. This is patients who have already received radiosurgery, either 1 or 2 courses, brain met velocity greater than or equal to 4 per year. It's limited to patients with non-small cell lung cancer, melanoma, renal cell, or GI primaries, greater than or equal to 18 years old, KPS greater than 70, no prior whole brain radiation or PCI. This study was recently activated in December of 2020, and it was endorsed by the SWOG CNS Working Group in February 2021. Next slide. So those are all the studies that I wanted to go over, and time permitting, I'm happy to answer any questions, and that's my email address if anyone wants to email me a question about those trials.
All right, thank you, Chad. I don't see any questions right now in the chat. So if people have questions, please put them up there, but while you're typing, I'll just say thanks to all of our speakers and presenters. We are planning on having a monthly Zoom call next month. You should have received that invitation. So if you did not, please reach out to me. So we'll make sure we have our lists synchronized. And my email is roy.decker@yale.edu. Should be pretty easy. Otherwise, yeah, please.
The date of the next committee. Yeah.
You're gonna make me look on my calendar and everything. Let's see. You know how bad Outlook search works. At least I have learned that. Let's see. It is SWOG radiation. April, May. SWOG, May radiation. So it's on May 25th, 4 to 5 p.m. Eastern time. So it should be a Tuesday. If and again, if folks don't have that on their calendar, reach out to me. I'll make sure you're getting your emails like you should be. All right, otherwise, seeing no other questions, I'm going to thank everybody, give you the last 4 minutes back. I appreciate all the great discussion today, and again, reach out with any comments or questions. All right, enjoy the rest of the virtual meeting.
Thank you.